Okay, welcome everybody. So this week, since I'll be away, we are going to finish up our lecture online. So I'll finish out the endocrine system. That means left we have to talk about the pancreas. And then what I'd like you to do is review the corrected case study for your work to make sure that the answers that you got from your group work are the right versions for when you want to study for the exam coming up. Okay, so the pancreas, when we look at the pancreas, the main job of our pancreas is to make glucagon. So that stimulates the glucose that's in our liver to be released in order to elevate our blood sugar levels. It also makes insulin. So what insulin does is it helps the cells in our tissues use our glucose. So it actually acts as a transporter to be pulled into the cell so that the glucose is able to be used for our energy and metabolism. The main disorder that we look at when we're talking about the pancreas then is diabetes. So diabetes is a disorder of carbohydrate, protein, and fat metabolism that's going to result from an imbalance between our insulin availability and the amount that we need to be used. We have different types of diabetes. So type 1 is where we don't have any insulin. We have a complete deficiency of it. The pancreas doesn't make it. Type 2 would be where we have insulin deficiency. All right, and then we have gestational diabetes. So gestational diabetes only occurs during pregnancy. So think gestation, pregnancy, and then it would just be diabetes that occurs during pregnancy. Our normal blood glucose ranges, when we look at lab values for individuals, we can measure them a different way. So fasting would mean that they haven't had anything to eat. And if we haven't had anything to eat, then we would expect to have a normal lower level for our blood glucose or our blood sugar range. So that would be 80 to 100. Now we'll give a little bit of leeway. You'll often see it to like the 120, 125 range. So you may even see normal written as 80 to 120. But once we really start getting above that range, we would consider them diabetic. So in other words, if they have a high blood sugar level, even if they haven't eaten, we know that they don't have insulin sufficient enough to meet the demands to use their blood sugar that's floating around in their plasma. Postprandial means that it's after they eat. So naturally, after you eat, your sugar level is going to go up, the amount of glucose in your blood, until your tissues absorb it and your insulin helps to get it metabolized and used. So we expect those to be a little higher. 2 to 3 hours would be 2 to 3 hours after they ate. So as you eat, hours afterwards, you are slowly breaking down, metabolizing, and using those foods, then we would expect those levels to start to come back down into that fasting range. So gestational diabetes means that they're going to have a high blood glucose level just during pregnancy. They didn't have it before they were pregnant, but now since they have become pregnant, they are having high blood sugars. This affects about 18% of pregnancies, so about 1 in 5 women will end up with gestational diabetes. It will be temporary. It should go away after the baby's born, although if women do get gestational diabetes, they have a 35 to 60% chance of getting type 2 diabetes later in life. As the baby grows, the placenta is going to produce more and more insulin blocking hormones, and that is going to cause the imbalance of the blood sugar levels within their body. During pregnancy, we monitor it. They may have to be doing daily or multiple times a day finger sticks to monitor the blood glucose level. We would want them to change their diet. Now they should have a diet that's lower in carbs, higher in proteins, and lower in fats. We'd want them to be doing exercise, and possibly if their diet, exercise, and monitoring isn't helping them to control their blood glucose level, they might have to go on medications to help them do it. So type 1 diabetes is an absolute insulin deficiency. It's a chronic hyperglycemia regardless of what they eat, regardless of their diet and management. So it's also known as insulin-dependent diabetes mellitus. In the past, you have heard it called juvenile diabetes because the most common cases are diagnosed in pediatric clients. It's the most common peds chronic disease in the U.S. But as childhood obesity and our sedentary lifestyle has grown in the United States over the past few years, we are seeing an increasing rate of type 2 diabetes in kids as well. So don't get them confused. When we talk about type 1 diabetes, we're talking about that pancreatic insufficiency. All right, and that's where they're going to be dependent on insulin. They're going to have to take insulin in order to manage their illness. 5 to 10% of all of our diabetes cases are type 1, so it is by far not the most common type of diabetes. That's type 2. We're not exactly sure what causes it. It could be autoimmune. We do see a family linked, which means that we think there's genetic components to it. There's also consideration that maybe environmental factors or viruses that attack the pancreas could have lead to type 1 diabetes. What happens then is that we have destruction of our pancreatic beta cells. So our pancreatic beta cells are the ones that produce insulin. Since they get to be destroyed and then we don't have them around, you're going to have insufficient insulin. So the lack of insulin then means that they have difficulty metabolizing their carbohydrates, fats, and proteins properly. So glucose then cannot enter our fat in our muscle tissues. It stays in our blood levels, and the cells then are depleted of the carbs, the fats, the proteins that they need to store for energy. So then people feel hungry. They're going to get what's called polyphagia, where they're going to feel excessive hunger even though that they've eaten. High blood glucose level then causes our fluid to leave our cells, okay, and go into our interstitial plasma. So you get an intracellular dehydration, and that stimulates our hypothalamus to think that we're thirsty, and you get the symptom of polydipsia. The excessive glucose that's being filtered by the kidneys then will spill over into the urine because the kidneys cannot manage it. And that's where you get the glycosuria, where they actually would measure the urine on analysis and there would be a high sugar content in it, or they'd actually find glucose in it, in other words. With the fluid being pulled out of the cells and into our tissues, you then end up with an osmotic diuresis that occurs. So that's where they have the excessive urine output, known as polyuria. So whenever we're talking about type 1 diabetes, I will post this link, and what I'd like you to do is go back and look at it after you're done listening to this talk so that you can have it to study from for your exam. Clients will have elevated blood glucose levels, polydipsia, that's the excessive thirstiness, the excessive hunger, the excessive urine, weight loss. They're going to have Kussmaul respirations, which are deep, labored breathing that is a strong sign of a metabolic acidosis going on. In this video link, whenever you're done, you can click on it as well in the PowerPoint. It is actually a video demonstration of a client who went to the emergency room with Kussmaul respirations. This would be a sign that there's a severe acid-base imbalance going on. Long term, these people are at risk for vascular or neuropathy issues. So in the United States, it's actually our leading cause of blindness and end-stage renal failure for clients. A major complication that we're concerned about with folks with type 1 diabetes is diabetic ketoacidosis. So whenever they can't use their sugars to have energy within their body, what happens then is they break down their fat, and then ketones are released. So our body isn't used to using fat as our main source of energy, and if they only use fat, then we're going to have an increasing number of ketones in our body, which then changes our acid-base balance, and we end up with a metabolic acidosis. The blood sugars will often be above 250, and remember, if it's a metabolic acidosis, then our pH would be less than 7.35, and metabolic, we'd be looking at a bicarb that is less than 15. In their urine, we would see those ketones. The hyperglycemia is going to lead to osmotic diuretics again, which will lead to severe dehydration, shift their electrolytes. They're going to end up with hyperkalemia because that potassium is going to leave the cells and enter the extracellular fluid, which can lead to cardiac complications. Type 2 diabetes then is where we have an insulin deficiency in that our insulin receptors aren't working properly. So it's not that we're not making insulin, it's that we've changed to an insulin resistance in our tissues. And then the glucose is going to increase in production by the liver because your cells are saying, hey, I'm not using it, I'm not getting enough of it, so I'm going to make more of it, even though the issue is more just that the receptor sites are not taking in the insulin like they should. This is known as non-insulin dependent diabetes mellitus, or NIDDM. Risk factors, this is the most common type, so it's going to be related to obesity, diet, aging, inactivity, and genetic factors. So insulin resistance, it's associated with a decreased number of our insulin receptors on cells. So we have less receptors, that means less of the insulin is going to be used. The glucose will not be carried into the cell via the receptor site, so it stays within our circulation and increases our blood glucose production. So obesity and inactivity actually are the things that increase our insulin resistance because they're not requiring the use of our insulin or our glucose within our body, so those receptor sites atrophy and die off. Beta cells are then unable to produce sufficient insulin, so we have an increase in insulin resistance. The decrease in insulin production, and what happens then is our increased glucagon production, and all of that is going to lead to high blood sugars or hyperglycemia. Approximately 90 to 95% of our cases in the U.S. are type 2, so the vast majority of them are. The risk factors, again, are going to be if you have a family history of it. African Americans, Hispanics, American Indians, and Asian Americans are more likely to get type 2 diabetes than Caucasians, and over the age of 40, with the thought being is that as we age, we tend to exercise less, we naturally lose our muscle mass and gain weight. The concern for type 2 diabetes is increasing also, though, among adolescents as we change our diets and things as a nation, have increasing rates of child obesity and less physical activity. We've seen a dramatic increase in recent years of type 2 diabetes in kids. So, risk factors, what happens is that the obesity, the more fatty tissue you have, the more resistant your cells become to insulin. You then also have a resistance the more sedentary you are. So if we're not using our glucose as energy during physical activities, our cells don't become sensitive like they should to the insulin within our body, and the sedentary lifestyle is going to lead to more of those receptor sites not working. Fat distribution, if you're somebody who carries their fat around their core, so their body stores are more around their abdomen or in an apple shape for their body shape, then they would be at increased risk than somebody who has fat distribution elsewhere, such as a pear shape like around their hips and thighs. They're going to also have those classic symptoms of diabetes, the excessive thirst, hunger, excessive urination. They're going to have more fluctuations in their blood sugars, though, than the other types. They could also have itching, fatigue, vision changes, and burning sensation. So that's those paresthesias again, those numbness, tingling, and burning within their extremities as the neuropathy destroys their nerve cells. They're going to tend to gain weight, right? And if we can detect their issues early and reduce their exposure to the insulin and the glucose within their systems by managing their disease, then we could decrease the risk of vascular and neuropathic issues. Okay, I'm going to take a break because my timer's at 15 minutes, and I'll start up with the rest of this in the next talk.